Hello and welcome to Medical Dialogues. I'm Mr. Zaman and today we'll be discussing an article that was recently published in the Primary Care Diabetes Journal. The article is titled Prevalence, Clinical Features and Complications of Common Forms of Maturity Onset Diabetes of the Young, or MODY for short, seen at a tertiary diabetes center in South India. So to talk about this article, we have with us Dr. V Mohan, who is an internationally acclaimed diabetologist and one of the authors of the article. Dr. Mohan is not only a renowned clinician but also an avid researcher, teacher, administrator, entrepreneur and philanthropist. He established Dr. Mohan's Diabetes Specialty Center, which has grown to a chain of over 50 diabetes clinics across 8 states and 32 cities of India. Active in the field of research right from the age of 18, Dr. Mohan has published an incredible number of 1,561 research papers which have attracted more than 1,75,300 citations. We welcome you to Medical Dialogues, sir.
Thank you. It's a great pleasure for me to participate in this and to talk to you on a subject which is very close to my heart, I must say, because I've been working in this field of MODY itself, Maturity Onset Diabetes of the Young, itself for almost 40 years now.
Great, sir. 40 years is a long time and the experience you have gained about MODY. We came across your recent article on Maturity Onset Diabetes of the Young. So if you can explain to us about this condition, what exactly is it?
So I was hoping that you'll actually ask that. Now, this condition called as MODY, M-O-D-Y, or Maturity Onset Diabetes of the Young, this term was first used in the year 1976. I was in my final year MBBS at that time 1975 I think it was. So I read this article as soon as it was published. And I said, this is quite strange because in the US, two scientists, Professor Stefan Fayans from the University of Michigan and Professor Robert Tattersall, who had gone from the UK to work with Dr. Fayans. These are two people who wrote this article. Now, what they were trying to say is that if you have a young patient in the US, say at that time young was defined as below 40 years. So anybody below 40 years was usually considered to have type 1 diabetes or insulin dependent diabetes. But they had a series of patients, 17 or 20 or something like that, who were below 25 years of age and yet did not need insulin and did not have type 1 diabetes. So they said that at that time, insulin dependent diabetes was called as growth onset diabetes. And what we call as type 2 diabetes, which comes in adults now, is called as maturity onset diabetes. So they said that this particular form of diabetes that they have detected in a few youngsters below 25 years of age does not look like the growth onset of the type 1 diabetes. It looks more like what we call today as type 2 diabetes, that time called as maturity onset diabetes. So they said we are going to call it as maturity onset diabetes in the young because it is occurring below 25 years. So it is a kind of revelation to the Western world that you can get diabetes below 25 years and still not need insulin and be treated with tablets. Now, when I read this at that time, I said, well, this is not uncommon at all because in India, type 2 diabetes at that time itself, this so-called maturity onset diabetes, used to come at a much younger age in Indians then and also now. So I picked this up and I said, this is something which I'm commonly seeing. My father was, of course, as you know, the first diabetologist of India. So I went back to him and then I said, Papa, read this article. We are seeing this day in and day out. I think we should publish on this. So he said, okay, you collect whatever series you have and you write it. So I wrote my first series of articles on MODY actually in the year 1984-85, by the time I finished my MD. And I wrote a series of 4 articles. And believe it or not, Stephen Fayans was one of the reviewers for all the articles. And so he got to like me a lot because I was reporting exactly what he had reported. But I must hasten to add that both Fayans' cases as well as mine, those days was based on clinical criteria. You had to be below 25 years and you should not need insulin. That's all. Very simple criteria. Many of those actually turned out to have type 2 diabetes and not MODY. To diagnose MODY or maturity onset diabetes of the young, you have to find a genetic defect. Now, these genes were identified only in 1992-93 onwards. So when Fayans described it in 75, and when I wrote my papers between 84 to 1984 to 86, the genes were not discovered at all. So what we thought clinically was MODY, we published, but actually there were not, many of them may not have been cases of MODY at all. Once the genes were diagnosed, the first gene for MODY was diagnosed, then the second gene, third gene, fourth gene. Today, there are 14 different types of MODY, and each MODY has its own clinical phenotype. In this particular article which you mentioned, I have mentioned 3 types of MODY: MODY 1, MODY 3, and MODY 12. 3 types I have taken. Why I have selected those 3? Because those 3 are the ones which respond to tablets. Okay, so once all the genetic defects were identified, slowly the refinement of the processes took place. From the year 2000 or so, for the last 23 years, we have actually been working on the genetics of MODY. But the progress is very slow because it took months, if not years, to get a genetic test done. We didn't have the modern technology. In the last 4 or 5 years, today we have technology which is so fast that within 2 weeks or 3 weeks, I can find out whether it is MODY or not. What used to take about a year, now in 2 weeks, I'm able to find out. So today, if any young patient comes, we'll first ask, is it type 1? Is it type 2? Is it MODY? Now in type 1 and type 2, we don't have a genetic defect. But in MODY, it is a single gene which gets affected. In type 1 and type 2, there are multiple genes. And there is also environment. For example, in type 2 diabetes, if you overeat, you will get diabetes. If you don't exercise, you will get. If you have stress, you will get. Family history will produce. If you eat junk foods, you will get. MODY is not like that. MODY is a pure genetic disease. It comes from one of your parents, not from both of the parents. So either the mother's side or the father's side, they will definitely have the disease. And the siblings also will get it. About 50% of siblings will also get it. So once you diagnose MODY, you know that in the whole family, and that's what Fayance and Tattersall later did. They collected large series of this MODY, and then they did these genetic studies and all that and published it. Now, since that interest started for me right from the year 1975 when I read that article, to 1980s when the clinical description came, to 1990s and 2000 when we started our genetic studies, we have continued our work in that. Later on, the Indian Council of Medical Research made us an ICMR center for studying monogenic diabetes, and we are still the national center, which means that if any patient is suspected to have MODY or one of the monogenic forms of diabetes, means with a single gene getting affected, they only have to send us the blood samples, and within 2-3 weeks we can not only say whether it's monogenic diabetes, whether it is MODY, which type of MODY it is, because only certain types of MODY respond to the tablets. Now, one question you might like to ask me is, why should you bother about all this? Why don't you just give some tablets or some insulin and be done with it? I'll tell you the importance and why Tattersall and Fayance in 1975 made that distinction. Before 1975, before Tattersall and Fayance published that, anybody below 40 years, they said you be on lifelong insulin because you are type 1 diabetic. That is how it is diagnosed. Science was so crude those days. Even today in India, if there is a child or adolescent who's 14 or 15, they'll say, it is type 1, treat with 4 times insulin. Now, if they turn out to have MODY type diabetes, they don't need insulin at all. You can completely stop the insulin and give them a sulfonylurea tablet which costs a few paisa, and that can be taken once a day or twice a day. It is so life-changing if you make the diagnosis of MODY. And that is the reason why diagnosing this condition becomes very important.
Yes, sir. I think that was a very detailed explanation of the 3 types of diabetes and how one can actually distinguish MODY from them. So, sir, in your article, it is mentioned that MODY often gets misdiagnosed as type 1 diabetes. There's still a lot of confusion about its diagnostic model. So, what factors or features one must look out for to come to its diagnosis?
Okay. So, let us take an example, a clinical example that will make it easier. Let us say there is a 15-year-old child, adolescent, who has been diagnosed to have diabetes. Now, once you're diagnosed to have diabetes, you have to treat that particular condition. But first of all, you'll have to ask, first of all, do you have diabetes? Number 1. Number 2, yes, you've got diabetes, blood sugars are very high. Which type of diabetes do you have? It's very important to ask that question. Is it type 1 diabetes? Because type 1 diabetes is a condition, if you stop the insulin, the child will die. Simply, they will die. The child will, if you think it's MODY and then without doing genetic tests, I feel it may be MODY. There's no question of feeling. You'll have to prove it because you're playing with a child's life. Suppose it turns out to be type 1 and you stop the insulin, try some tablets. Within 2-3 days, within a week, the child can die of diabetic ketoacidosis. So you'll have to ask, is it really type 1 or not? Now, for type 1 diabetes, there are certain criteria. First of all, in type 1 diabetes, usually the parents will not have diabetes. So we don't start by doing genetic test for everyone. What I've taught all my team and my doctors and everyone to do is take a pencil and paper and draw the family history of diabetes. That is how Fayans and all taught us. So what you do is you draw the family history, go from the parents to the grandparents to the great grandparents. In the case of MODY, there'll be 3 or 4 generations of diabetes. You can see it coming from the great grandfather to the grandmother to the father to the somebody like that. It will be going for 3-4. This is a very, very rarely occurs in type 1 diabetes. So looking at that, you can say, hey, this looks like MODY to me. There is a simple test called a C-peptide. C-peptide test just measures how much insulin is there in your body. You can do it in the fasting before you take any food. Then you take breakfast, and after 90 minutes, you draw the blood again. So along with the glucose test, you can do the C-peptide test. C-peptide is a direct measure of how much insulin is being produced by your pancreas. In the case of type 1 diabetes, it will be near 0. There will be absolutely nothing, or very, 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 very low levels will be there. In the case of type 2, there will be a lot of insulin because the type 2 are usually obese. So when you look at a child walk in itself, suppose you find a huge child coming, a very big made, huge, there'll be acanthosis on the neck. If you just feel the neck, you'll find some kind of velvety thing. There'll be insulin resistance. All this is type 2. MODY doesn't come like that. MODY will mimic type 1. Okay, they'll also be thin, but the family history is the first clue. Then you do the C-peptide test. In MODY, C-peptide will be preserved, whereas in type 1, it is completely absent. Then there are 2 tests for type 1 diabetes. It's called GAD antibody test and zinc transporter test. Those tests are specific for type 1. Now you do those tests, and if they come positive, strongly positive GAD, strongly positive zinc transporter, it is type 1. You don't have to even do the genetic testing for MODY. You can stop there and start treatment for the insulin. Now, many people don't do all these tests. They straight away say, young child, type 1, we'll treat like that. What happens is, when they come to us, we don't take it so lightly. Even if they say it's a proven type 1, I say, I would like to prove it. Sorry, I'd like to prove it, because it's like a judge sitting and giving a sentence. Before a judge gives a sentence, every piece of evidence the judge has to see. So now I am sitting in the position of a judge. Here the parents are coming and saying, here is my child, tell me what you can do. Type 1 diabetes means 4 times insulin for the rest of your life. If it's a girl, you can imagine many of them can't even get married, and there are a lot of problems with that and all that. Now, here what happens is that when we do these antibody tests, if they come positive, then we know that it is type 1 diabetes, and you can proceed with the treatment. Now, if you do the antibodies and they come negative, okay, that's a clue. Why is the antibody negative? In type 1, it should be positive. Of course, having said that, about 10-20%, it can be negative in type 1, but 80% it will be positive. So that's the next clue we are getting. C-peptide is preserved. There's some insulin. Family history is there. It's going through 3 generations. The GAD antibody and the zinc transporter have come negative. All these are the signs of type 1. Is this really type 1 or not? I'm getting convinced that this is not type 1. Then I'll send the blood for the genetic test. You may say, why not send everyone for genetic test? It's not cost effective. Genetic test is quite expensive. We try to do it free wherever possible for people, and then I have to pay for it. Somebody has to pay. ICMR has to pay. Somebody has to pay. But they are not very cheap tests. They can cost 10,000 rupees, 15,000 rupees, and even if you do a small panel, it costs 3,000 rupees. So these are not like completely free kind of thing which you can do. So we have to have an algorithm and say, I've ruled out type 1 now, GAD is negative, C-peptide is present, family history is there, and so now I will send the child for genetic testing. Now when you send for genetic testing, what happens is a whole panel, we have 78 types of monogenic diabetes. MODY is 14. But there are many other types. Neonatal diabetes is there. MID is the maternally inherited diabetes deafness. Genetic syndromes are there. So many types are there. There's about 78 types. When we do the test, we don't do for one MODY or one. The entire 78 is in one panel we do. Then it will come. This is MODY 3. This will respond to sulfonylurea, HNF1 alpha mutation. It will respond to sulfonylurea. Once we get that, then we stop the insulin and treat the child with the sulfonylurea. So this is what I'm describing. This whole process is called precision diabetes. So what we're actually following is precision diabetes. We're not treating everybody as if one size fits all. I always show when I give my talks on MODY, I show a picture of a child wearing a huge glasses. The glass will come up to that. or a child, another boy wearing a shirt which is 10 times bigger than him. And I say, can you do this? Can you give same shirt to everyone in the world? Can you give same glasses size to everyone in the world? You can't do it. Similarly, can you treat all diabetes as if they are the same? You can't. You will have to have some kind of an algorithm, some kind of thing whereby you find out which is the correct type of diabetes. So that is called precision diabetes. So once you do this precision diabetes approach, you can't make a mistake. And then you find out which type of MODY you have, and then you can treat it. Now, the advantage of doing all this is that lifelong insulin can be avoided for many children. I've got hundreds of MODYs now. In that particular paper, I had a few cases which you described because I had to do other things, compare type 1, compare type 2, and so on. But in other series of MODYs which I've been publishing over the years, we have published 40 papers on MODY now. And in all those papers, we've described different aspects of. I have a separate paper on MODY 1, on MODY 2, on MODY 3, on MODY 5. Separate series of papers we have published because we are the National Center for MODY. So making a proper diagnosis is the first step in giving the treatment.
Very well said, sir. The algorithm actually is the stepwise arrival at the diagnosis, and confirming it after taking a proper history is any day a much better approach.
When I was a student, we'll do a test for jaundice. Urine looks high colored. Oh, this person must be having jaundice. So we do the jaundice test, and then he's got jaundice. Okay, and we used to wonder 50 years ago why some people with jaundice within 3 weeks they are back to work and everything. Some deteriorate, and they ultimately die also. Just wonder why all this is happening. Today we know that there's hepatitis A, hepatitis B, hepatitis C, hepatitis D, hepatitis E, each one with its own prognosis. Hepatitis A, you'll recover in 2-3 weeks' time. Hepatitis B, you'll probably be a carrier throughout life. Hepatitis C, it comes through blood transfusion. So you know that you got it when you went for some blood transfusion. Each hepatitis has got its own course. You take breast cancer. All breast cancers are not the same. You can get hormone positive, hormone negative. You can get triple hormone positive, triple hormone negative. Each one has a different prognosis. How long you will live, what treatment will be given to you, all depends on, they don't just put under the microscope and say, you got cancer, now you start treatment. That has to be subclassified to find out which type. Then only they treat. This is what is called as precision diabetes, precision medicine. Now, in the case of diabetes, it has not been followed like that. Unfortunately, people just say, okay, give some diet, give one tablet, that doesn't work, give another tablet, and all that. I think the days have gone when we have to now really start focusing on which type of diabetes we have, and then start giving the treatment.
Very true, sir. I totally agree. I'm in awe of the algorithm that you have set up. So in your study, you mentioned about the prevalence, clinical features, and complications. So what were the results drawn?
Yeah. So in that particular paper, I had 3 types of MODY only included. The other MODY types we excluded for that particular study because we wanted to compare it with the type 1 and type 2 diabetes. So we had MODY 1, MODY 3, and MODY 12. And this MODY 12 is actually not much is known about it. This is one of the first publications I mentioned in that paper, that MODY 12, people didn't know what age they get it, whether they'll develop complications, whether they'll respond to sulfonylureas, nothing much. If you Google and see, or if you look at the other publications, MODY 12, nothing much is known. So this is one of the first papers on MODY 12. MODY 1 and 3 are very well known, but MODY 12 is one of the first publications. So on these 3 types of MODY, what we did was, we compared them with age-matched and duration-matched patients with type 1 diabetes and type 2 diabetes. And we wanted to see whether people with MODY will develop complications just like the type 1 and type 2. And to cut a long story short, yes, they can. So MODY is not an innocuous condition. It is not something which you diagnose and say, this nothing will happen. There's only MODY, so no need to treat. No, you have to treat. They may not need insulin. They may be responding to sulfonylureas or other tablets, but you definitely have to treat them and diagnose them. What I also showed in that paper was, because they were wrongly diagnosed, till they came to us, many of them were treated as type 1, they were given insulin, they were given metformin, which works better for type 2, but not for not for MODY, where sulfonylurea has to be given. So because of this misdiagnosis, many of them delayed by a few years, which is the reason why probably they developed the complications. So one of the things I'm making in that paper, as points I'm making, is diagnose it early. From the time, especially in young people, you're talking about young people who have lived 30, 40 years or more with the disease. So why not spend some time and effort find out which type of diabetes it is, diagnose it early, and for that particular type of diabetes, even if it's a MODY, which subtype it is, you find out, and then you give the treatment and get the sugars under good control. And if they have blood pressure, keep that under control. If they have cholesterol, keep that under control. I call it as the ABC. A stands for A1C or HbA1c, which is control of sugar. B stands for blood pressure, and C stands for cholesterol. So I always end for D. Of course, some discipline also you need. Discipline, diet, exercise, all will come under D. So I just say very simply that if you have A, B, C, D, nothing can go wrong with you. And no diabetes will affect you in any way. And you can have a long and healthy life despite diabetes. In other publications have shown that people can live beyond 60 with 60 years of diabetes, 70 years of diabetes, and not have any complications. I've reported on another series where people have crossed 90, 95, and even 100 years of age with diabetes after finishing 60 years, and they're also doing well. So that's the other side of the coin, that if you really look after them, they can have a very long and healthy life despite diabetes. So the point I'm trying to make is, once you find out which type of MODY it is, which type of diabetes it is, then you can treat it accordingly. Just out of interest to listeners, I would like to say that there is a type of MODY called MODY 2. Okay, now MODY 2 is a very mild form of MODY. Okay, and once you diagnose MODY 2, they don't need any treatment. That is the only type. It's called GCK MODY, and GCK MODY is one type of MODY which will not develop complications. The diabetes will remain mild throughout. They will never develop retinopathy or nephropathy or kidney or heart or feet or any complications in their lifetime. You'll do more harm by treating them than not treating them. So if you by chance find out that they have MODY 2, you can stop all treatment, maybe a little bit of diet restriction, and that's all is needed. So you can see that it works the other way also. Maybe over treatment can also be avoided if you make the correct diagnosis.
Great, sir. And what was the conclusion of the research? Any message that you would want to give out?
I will give it as a message for doctors, for public, for everyone. Number one, not every young adult or a child or an adolescent who is diagnosed to have diabetes necessarily has to have type 1 diabetes. Of course, keep type 1 diabetes in mind, because if it is type 1 diabetes and don't give insulin, the child will die. But it does not mean that every child with young onset is type 1 diabetes. What Fayance and Tatchall showed in 1975 itself and what we showed in 1980s still holds true in 2023, that not all young children, not all young adults with diabetes have type 1. They can have other forms of diabetes. They can have type 2, for example. If they have type 2 diabetes, you can treat them with metformin, diet, exercise, weight reduction. In MODY, all these doesn't work because MODY is already thin people. So the diet, exercise, weight reduction, all that doesn't work in MODY, but in type 2 it will work. Now, if you find out it is MODY, you've done the genetic test, you found it's MODY, find out which type of MODY it is. If it's a type of MODY like MODY 1 or 3 or 12, these are the 3 types of MODY which respond to sulfonylurea. Immediately stop the insulin, put them on sulfonylurea, very cheap. Sulfonylurea has been around for 70 years now. So we know how they work, we know everything. So if you give, they're very cheap. So they're available everywhere in the world. Okay. So if you give them the sulfonylurea, you can stop the insulin. Imagine the child's life. Completely all insulin's gone 4 times a day. 4 times a day into 365 days. Imagine how many times the child would have been poking. All gone. Just 1 tablet, finished. It's like a miracle happening to that child. And so make the right diagnosis. Think of MODY, especially if you find some unusual features in type 1. Very strong family history. Why are they having such a strong family history? I've heard that type 1 does not have family history. Parents don't have, grandparents don't have. Why is that they're having? Then you do simple tests like C-peptide, GAD. These are all available very easily. You do those. And if they turn out to be positive, okay, it's type 1, you can continue. If they come negative, then contact us. Ask us, can you do this genetic test for MODY? I've done all this, the basic screening algorithm, as you said, and it doesn't look like type 1. So can we, give the benefit of this child undergoing a MODY test, a monogenic diabetes test? And if it comes positive, can we change this child's life? So remember that all diabetes in the young is not type 1 diabetes. Think of other forms of diabetes. Maturity onset diabetes of the young, type 2 diabetes, all occur in children. So if the child has one of these forms of diabetes, I would say it's much easier to treat than injecting 4 times a day with insulin.
Thank you for your valuable insights.
My pleasure. So if anybody wants to contact me for any personal consultations or clarifying doubts, it's Dr. Mohans at diabetes.ind.in. I'll be more than happy to answer them.
Thank you for your time. That's all for today. Stay tuned to Medical Dialogues for latest updates.
Never miss a medical update from Medical Dialogues. Like, subscribe, and press the bell icon.